Thank you very much, Alan. My name is Yves Rolland. I'm a geriatrician working in the Gerontopole of Toulouse, and I'm happy to be here to speak about body composition and mortality in the elderly. And during the first part of my communication, I will report some background about the association between fat mass and mortality and body fat distribution as well. And I will also speak about muscle mass and mortality, and you will see that there is more question than evidence. And I will raise some question, but I think there is still a lot of work to do to better understand, at least in the elderly, the relationship between these two body compartments and the risk of mortality. And in the second part of my communication, I will report some results from the EPIDO study. The EPIDO study is a large epidemiological study carried out in Toulouse. Already were included at the age of 75 in 92, and they have been followed. And we've got a body composition at baseline, and this cohort is a great opportunity to better understand the link between body composition and the risk of mortality. So we can start by the association between fat mass and mortality. And you are, of course, very familiar with this kind of curve, of U-shaped curve. And you can see that when you've got a low BMI and when you've got a high BMI in both men and women, you've got a higher risk of mortality. And this kind of curve have helped to define definition of overweight and obese patient. But what you can also see is that when you are on the oldest group of this large cohort, the association between the BMI and the risk of death seems to be less important than in the adults. So the impact of the BMI seems to be less important when you are getting older than when you are young. The BMI is a proxy of adiposity, and this tool is very useful in clinical practice, but it has large numbers of well-known limitations, and one of them is that it doesn't take into account the fat distribution, and this fat distribution has a huge impact on the risk of some events, such as the cardiovascular event, and this has been reported for years. That when you've got a high waist circumference or when you've got a high waist to hip ratio, which are both indicators of abdominal adiposity, you've got a higher risk of death, even after adjustment for the BMI. So this distribution of the fat is something very important when we think about the link between the fat and the risk of death. Another limitation of the BMI is that it's not able to capture the modification of the body composition when you are getting older. And as you know, you've got decline of the lean mass, you've got also an increase of the fat mass with an increase of the visceral fat and also a decrease of the lower body subcutaneous fat. And of course, this modification cannot be captured by the BMI because these changes can occur independently of changes of the body weight, of the total adiposity and the waist circumference. This result of some data have reported that when you are getting older, this modification of the fat distribution and body composition may explain some results reported in the literature. And for example, in this paper, the authors have tried to report the numbers of years of life lost due to obesity. And the idea were to give a strong message, a better message than the association just with the BMI, with mortality, but to say when you are obese, you lose some year of life. And this would be a good way to give a clear message to the population. And what they have found is that when you are getting older, you've got some loss of year of life. But in some condition, when you've got some distribution of the fat, for example, in the black woman, and a different kind of body composition, more muscle mass. It seems that when you are in the oldest group, you don't lose year of life, but you've got an increased life expectancy. And you can see on the lower part of this slide that even in the very high BMI, the oldest women have a slightly increased life expectancy across most of the obesity range in the old range of this analysis. So this kind of data have resulted in what is commonly called the obesity paradox, which means that when you are obese, you've got, of course, a higher risk of comorbidity. And so being obese is not a good thing because you will have a higher risk of comorbidity. But when you are overweight or when you are obese, you have a better survival outcome than the normal weight when you are exposed to some stressful event, such as an hospitalization for heart failure, for a stroke, for kidney disease, when you've got a high blood pressure or diabetes. And it seems that when you are getting older, the benefit of a higher reserve of energy in the case of a stressful event offset the deleterious effect of the BMI on some risk of cardiovascular disease. And this is a way to explain this obesity paradox that we can observe in the older patients. So overweight and obese older have better survival outcome than the normal weight when they're exposed to a stressful event. And of course, this data raise some question about the current National Institute of Health guideline, who suggest to define the overweight and the obese patient with the same cutoff when you are an adult or when you are an older patient. And most of the experts suggest that the cutoff may be higher, maybe 27, 28, when you are getting older. Large numbers of work have been done on this topic, and some of them have reported that the percentage of fat wherever it is on the waist, on the hip, is associated with a lower risk of mortality when you are getting older. And this was reported in this study, where you can see that higher whole body fat percentage as well as higher proportion of abdominal fat was associated with lower whole-cause mortality, at least in men. It was not exactly the same result in the woman, but you can see that wherever the fat is, it seems that the risk of death is less important. I must raise the fact that there are large numbers of conflicting results in this area, and a lot of work still needs to be done. And for example, in this work performed by Jan Johnson, he reported that both BMI and waist are associated with a lower risk of mortality. But when you adjust both the BMI and the waist on the waist and the BMI, you've got different results. It means that when you look at the BMI adjusted on the waist, the BMI adjusted on the weight is associated with a lower risk of mortality, which means that when you've got what we call a pear shape, you've got a lower risk of mortality. But when you've got a higher waist circumference adjusted on the BMI, which means when you've got a pear, not a pear, an apple shape, you've got still a risk of mortality. So this waist circumference, in this paper at least, seems to remain a risk factor for mortality. So it's not very easy to have conclusion about all this data, and I think that all these conflicting results in the field of obesity and fat is the result of different methods the heterogeneity of the population, the statistical analysis. And I think there is still a lot of work to do in this domain, and to see if the frail elderly patient is a congress about frailty, but it would be very interesting to see if the frail elderly patient have better outcome when they are obese or overweight compared to the robust. So the conflicting result in the literature may be the result of the heterogeneity of the elderly population included in this data. What about the link about muscle mass and mortality? As you know, sarcopenia can be defined by the low amount of muscle mass, poor muscle strength and poor physical performances. And in theory, it seems very logical to think that when you've got a higher amount of muscle mass, you will have a higher amount of amino acid reserve, a better hormone, a better glucose level control, more strength, less fall, and then it results in a lower rate of infection, lower immunodepression, less inflammation, less fracture, better function, and at the end, you will have a lower risk of mortality. This is, in theory, quite logical. And when we look at the literature, you've got large numbers of papers who have assessed the association between physical performances and the risk of mortality. And most of the papers that have been done for decades report the same association. When you've got poor physical performances, you've got a higher risk of mortality. And this was done 20 years ago, exactly by Rolland, who was the father of the SPPB. And you can see that for each point of the SPPB, you've got a higher risk of mortality. And of course, it has been done more recently with a very nice paper. For example, this paper suggests that when you've got a low walking speed, you've got a higher risk of mortality. So once again, all this paper suggests that when you've got a low physical performances, you've got a higher risk of mortality. And this is quite consensus in all the paper. It's always the same demonstration. The question whether muscle mass by itself is a risk factor for mortality is still an open question. This is another question, whether muscle mass by itself can predict mortality is still an open question. In fact, there are two kinds of population in this domain. There are some papers about the risk of death in patients in the context of wasting disease, such as cirrhosis or cancer. And in this paper, the patient have some cachexia, and they clearly demonstrate that in this population with a wasting condition, a low amount of lean mass is strongly associated with a risk of mortality. And this was done in this paper with patients with cirrhosis, and it has also been done in several papers with different kind of cancer. And for example, in this paper with breast cancer survival, they find also a correlation between the baseline amount of lean mass and the risk of mortality. What do we find when we look just the patient with a healthy condition? If we put away the patient with cachexia, with a bad condition, with cancer, what can we find? There are conflicting results. This is one of the papers that, not so many papers in fact, but one of these report that when you've got a low amount of fat-free mass divided by height, it was the indicators that they use to define sarcopenia, the lower quartile had a lower proportion of survival, which means that when you've got a low amount of lean mass, you've got a higher risk of mortality. But you can see that in the three top group, in the three quartile, the differences are not so evident. The three over curves on the top are quite similar. Other papers do not report this association between lean mass, muscle mass, and the risk of mortality. And for example, in the health ABC study, Han Newman did not find an association between muscle mass and the risk of death. This association was only reported for strength. As I said before, when you've got low physical performances, low strength, in this case it was assessed by the grip strength, you've got a higher risk of mortality. But she did not find an association between the muscle mass and the risk of death, wherever it is, in the leg or in the arms. Another paper has reported nearly the same result. It was done by Matteo Cesari in the in-county study. The assessment of the muscle mass was done on the calf with a CT scan, and it was done in nearly 1,000 participants, and it's find nearly the same thing. The curves are nearly the same when you divide this patient according to the muscle mass and when you group them in different range of BMI. But and find an association between the muscle mass and the risk of mortality. So once again, it is quite complicated to understand what's going there, but there are no definitive conclusions in this topic.